Welcome. Welcome, everyone. We're pleased to have you join us here today in the Health System Performance Research Monthly Webinar. This month, we're here to talk about the interventions that address inequities in Ontario health teams. Please use the chat to say hello and let us know where you're from. Just watch for the people to be able to get the chat in. Can we just double check? I don't see chat, that it's enabled, because usually we do see lots of chat right off the bat. People have been in here before and they know what to say. So, there we are. Andrew Posen opening it up. Louise Petrix, Guelph Wellington, Nipissing, John. Welcome, John. Just met John a few weeks ago. And here they come super fast. Alexandra from Ottawa Health, Angela from Grey Bruce, Anne from Connects Ontario Health. Welcome. Welcome to everyone. Kids Come First in Eastern Ontario. From Windsor, from Brockville, from Halton region. Hello, Ganesh from St. Elizabeth Health, and many OHTs, I can imagine. Port Dover. Welcome, Marjorie. Hello, Sam from Toronto. Welcome to everybody. So glad that you're able to join us here today. And we are going to have a really great adventure today through quite a number of speakers. And so please come in, introduce yourself. People are still coming on quite quickly, so I'll wait just a moment before moving into our land acknowledgement. And thank you. Welcome, Roxanne from the Réseau de Mieux-être. That sounds lovely. Olga from Northern, Michelle Sparling from Halton, Brenda, nice to meet you again. I just met Brenda a couple weeks ago, KW4. I had a good chat about the work that they're doing. Sarah Good from Great River OHT, welcome. So happy to see you here and joining us today. So if we could just go on, I will start off today with our acknowledgement of the land. I'm speaking to you from the University of Toronto, and for thousands of years, it's been the traditional land of the Huron-Wendat, Seneca, Mississaugas of the Credit. And today it's still home to many Indigenous peoples from across Turtle Island. Always grateful that we here at the University of Toronto have the opportunity to work on this land. And we also have the opportunity to work with many OHTs, many of whom have substantial and significant Indigenous peoples working within and as part of and leading work with people who have traditionally been on this land for thousands of years, the original inhabitants. So I welcome you to acknowledge the land you're on, also in a few weeks ahead of our acknowledgement of our National Day of Indigenous Healing coming up. I will start off with this poll. And if you joined us for an HSPN webinar previously, I think this is going to be very interesting today. It's a slightly, it's a new topic in some ways to actually be talking about the interventions and to be focused here on equity. So have you joined us for an HSPN webinar before, or is this your first event? See, we have just over 150 people who have joined us already today. So let's see. At least when I get above 100, and some people are still writing in, and I think it's slowing. So maybe we could show the poll. And interestingly, very, very interesting to see if we can share those results out. I can do that. Oh, that was my fault. We actually have a few more people joining us for the first time. Almost 38% of people, or 38% of people, are joining for the first time today. So welcome to the Health System Performance Monthly Webinars for Ontario Health Teams, and welcome to this special event on Indigenous, interventions to address health equities. So welcome to that. I have one more poll that we could go to and take this one down, and that is to understand what your awareness is around interventions to address health equity. So the actual interventions, not just about planning, about actually doing things and what is actually happening in your community and around Ontario about interventions to address inequity, and perhaps international examples. We're going to have a great opportunity today to learn about some international examples of what's happening. So you're where you are, and today is really about raising awareness, expanding knowledge, and allowing an opportunity for us to share about what you're doing and what's happening across and around the province, and as I said, international. So we're slowing down on the poll, people entering, so maybe we could go ahead and end it and share it back out with folks. And I see it looks like it's a very, what we would in science call the normal distribution, with most people in the middle and just a few people on each end. So somewhat people have a little bit of knowledge, but 60% of our respondents today in that kind of 4 to 6 range. And so we are going to shift this by the end of the day. So welcome to everybody. And if we just go back one slide, Paul, we have the headshots of people that are joining us today. And as you can see, we have an all-star lineup, and B, a very full lineup today. You're going to hear from all of these speakers. We're going to start off with Dr. Sarah Sowden, who's a public health consultant within the Office for Health Improvement and Disparities, Northeast of England. Her research there aims to enable the NHS, local government, and wider system partners to better promote health equity and reduce inequalities in health and care access, experience, and outcomes. Interestingly, she has as her career mission to improve the effectiveness of action taken to address health and healthcare inequalities. That's her career mission. I appreciate people with a purpose. Sarah leads applied health research in health and healthcare inequalities at Newcastle University, including, as we're going to hear today, a lot about the unfair and the deep end programs. So why don't we go ahead and we can move into the first of Sarah's slides, and I will come back to the other speakers. We'll skip this one for now. I'm just in the interest of time. Paul, you're starting off.
Yeah.
And then we're going to go into have Sarah lead us in. So that's great. And for those people who have been around for the webinars and equity, Dr. Paul Wankah has been hosting all of these to date. First on what is happening for health equity, then on building capacity, then on measurement, and now on the intervention. So Paul's just has, I think, a few good slides to orient us to the material and how we're going to go ahead. So I'll turn to you, Paul, and then why don't I leave it to you to go right into Dr. Sowden.
Yeah. So thank you, everyone. So just like a brief recap of a key concept that we had previously discussed, disadvantaged social groups such as low-income communities, racialized populations, or people living in rural or remote areas consistently have worse health outcomes and also opportunities to health than more socially advantaged groups. In previous webinars, we had identified these different groups and also argued about like the unjust, that these health differences were unjust and avoidable. So this slide shows finding from the previous HSPN patient survey that reveals that across OHTs, patients that responded that they had difficulties in paying bills at the end of the month had worse overall health outcomes than patients that had never had difficulties paying bills at the end of the month. We can observe a clear social gradient across these groups, meaning something has to be done to improve health outcomes for patients who sometimes and always have difficulties paying bills at the end of the month in our OHTs. This webinar is a shift from describing the problem towards planning and acting to solve this problem. So acting to improve equity encompasses all of those interventions and programs that are developed and implemented to improve outcomes and care experiences for socially disadvantaged groups. A useful way of reflecting about equity promoting interventions is to focus on the level of interventions, namely acting upstream or at the system level, acting midstream or at the organizational level, and acting downstream at the clinical level. And also, we can also reflect on the scope of the intervention with a special focus on a proportionate universalist approach. So regarding the level of interventions, OHTs may enact downstream interventions that aim at addressing the immediate health needs of disadvantaged groups. For instance, you can actually develop some programs or interventions that ensure diabetic or chronic heart failure program is accessible to a socially disadvantaged group like low-income people. OHTs may also enact mainstream interventions that seek to create impact by addressing the social needs of disadvantaged groups. For instance, OHTs may leverage social workers and community workers to link low-income people to social assistance.
Recording in progress.
OHTs may also name upstream interventions that focus on addressing the root causes of inequities. In this case, OHTs will play an advocacy role in shaping policies and regulations that impact the living conditions of low-income people, such as the living wage or a progressive taxation program. So OHTs can act at multiple levels, and as we know, addressing the root causes of inequities is one of the most effective ways of actually improving health outcomes. Now, for OHTs generally have to deliver care to a specific attributed population. Regarding the scope of interventions, a universalist approach means developing interventions where everyone has access to services, hoping that disadvantaged populations also benefit from these services. However, these interventions can also exacerbate inequities if special considerations are not taken for socially disadvantaged people. Through a proportionate universalist approach, OHTs can develop targeted interventions that can specifically address the unique needs of disadvantaged people while concomitantly delivering services to the general population. So today, we will hear from speakers that are actually carrying out equity promoting interventions at the international level and in Ontario health teams. We hope to draw key lessons and success factors from their experiences. So Walters will proceed in presenting our next speaker. I think that is Sarah, who was previously presented here. Sarah.
Thank you, Paul, and thank you, Walter, as well, for your generous introduction. So, as Paul Walter said, I'm Sarah Sowden. I work at Newcastle University, and for those who don't know England well, Newcastle upon Tyne is in the north of England, and it's certainly a good area to work in if you want to address health and care inequalities and achieve health equity, given that we have some of the highest rates of poverty, ill health, and early death in England. So an excellent overview by Paul of some of the principles around, guiding principles around what works and how can we address inequalities and improve health and care equity. And so I'm delighted to join you all today to talk for 15 minutes around what we've been doing in some of the activity that I've been involved in England. So our roadmap for the next 15 minutes together, I'm going to just present some of the research that we've done around the evidence-based guiding principles for addressing inequalities. And then provide some examples of some activity that we've been doing, specifically the Deep End and Unfair Research programmes. I'm also very conscious that I'm going to be giving a bit of a whistle-stop tour of all of this work. So I'm going to provide all the links to where to find out more if you'd like to find out more about these programmes, because I can really only give you a snapshot today. So I'd like to start with a piece of research that we published in 2022, all about, it's called actually Levelling Up Health, a practical evidence-based framework for reducing health inequalities. And it actually covers many of the points that Paul has been talking about. But here, the aim of this piece of work was to present a practical evidence-based framework of guiding principles that help to level up health. And the choice of the word levelling up is that is something that's quite hot on the politics and political landscape at the moment in England, and something that people are talking about a lot. So that was the framing of it. What we know is the literature on inequalities remains quite imbalanced around describing the problem of inequalities rather than finding solutions. So what we did was we did a review to look at, well, what were the guiding principles that underpinned a lot of this work? And Paul has touched on many of this already. Just previous slide a moment, please. So that there's some key components into this, which is around healthy by default and easy to use initiatives, taking long-term multi-sector action, so working together across organisational boundaries, which I know is something that you all work on very closely here in Canada. Locally designed focus, targeting disadvantaged communities. So we talked about the proportionate universalism and then the specific targeting, and then of course matching resource to need. Next slide, please.
This meeting is being recorded.
Another overview slide that I just wanted to share with you was about another piece of work that we did, and this was specifically looking at what could be done to reduce health inequalities in general practice, so in family practice medicine, and it took a realist review, an action framework approach, and again, this is a big piece of work and I haven't got time to share all of this, but I think it's really important to share these guiding principles that really came out of this work when we looked across all the literature about what were the successful interventions to intervene to address those imbalances that we all know are there in health and care. And those 5 key principles were being connected. Interventions and services should be understood, designed and delivered as connected components of coordinated action. They need to be intersectional, flexible, inclusive, and very importantly, community-centred. And if you would like to find out more about the research, the publication's there with a link, and there's also a toolkit which has many more bits to it that I've included the link to there as well. Next slide, please. So let me just take one example of a targeted disadvantaged communities approach that we're taking here in the northeast of England. Next slide, please. So I'd like to introduce you to the Deep End General Practice Networks. So this was a movement that started in Glasgow in Scotland over a decade ago. And it was about bringing together GPs, which is general practitioners, which I understand, I think is the term would be family health practitioners here, serving the most deprived communities to share learning and ideas and to address what is known as the inverse care law, so that we know that the distribution of resource and indeed the level and quality of care is disproportionately patterned across our population. And indeed, unfortunately, in the areas where health needs are greatest, we find that workforce pressures and the delivery of care can unfortunately be the least. And so this is something that it was really a big driver towards the inverse, addressing the inverse care law. So the idea of deep end came from the concept of a swimming pool. Professor Graham Watt, who was a GP who worked in a very socioeconomically disadvantaged area in Scotland, talked about it being like treading water, where what you can see is that in areas of blanket deprivation, you have very, very poor health and low life expectancy, and people are drowning. Whereas those in more socioeconomically advantaged areas are doing exceptionally well, have got their head well above the water and are coping fine. And so that concept translated into the logo for Deep End. And as you'll see from that map there, there are a number of Deep End practices across the UK, but also internationally as well. And so it's become and is growing even more to be an international movement. Next slide, please. So what is the Deep End network in the North East and North Cumbria region of England, which is where I work? So we established in 2020, and our model is very much a partnership model between family practices, public health consultants working in local government and local organisations, for example, the Office for Health Improvement and Disparities. We have a big research component to what we do. So I lead a research element to our Deep End work through the auspices of our applied research collaboration, which Newcastle is a part of, but it includes all of the regional universities in the northeast of England. NHS England, which is one of our organisations that works on a regional footprint and a national footprint. And also we have more locally in the northeast and North Cumbria something called the NHS Integrated Care System, which I know Will has spoken about at a previous webinar. And it is the ICS, the integrated care system, that provides the financing for the interventions that go on in the deep end. And then for the research, we get research funding in to evaluate and co-design those interventions. And so the aim of the network is to bring together these family practices serving the most deprived communities to share learning and ideas, work collaboratively to change the way primary care is delivered, and create positive change for patients, practices and communities. Next slide, please. So one of the approaches we took, given the guiding principles that we know around what works to address inequalities, is that we went out to listen. So we had a view that we wanted to create a deep end network in our area, similar to what they've done in Scotland. We thought it would be useful, but we really needed to go out there and ask people on the ground, well, is this something that you want? How could this help you? And we also needed to understand the challenges of delivering primary care in areas of severe socioeconomic deprivation, and including the experiences through the COVID-19 pandemic. So that we had a research aim around a greater understanding. And through this understanding, we wanted to co-create with these primary care practitioners and the wider network around what could we do meaningfully and impactfully to address needs and support reducing inequalities and improving health equity. And you can read more about the research at the link there. Next slide, please. I don't have time to go into the detail of the findings from the research, but as I say, you can read it there. But I'm just going to share some of the key themes that came out of this work. It was a qualitative piece of work, and we undertook some thematic analysis. And I'd be interested to know how much these resonate or not with your experiences. But what came out loud and clear from our work was the volume of complex patient need that presented in the deep end. Mental health issues were a huge issue and were often very interlinked with physical health and presentations. So there was really an intermeshing of very complex need, and mental health was always there as part of that. The recruitment and retention challenges that we'd heard about from theory and practice, theory in the inverse care law, were very much borne out in practice. People felt that they were very much struggling to recruit people to work in these areas and also retain staff once they had recruited them. And there was a wider feeling that the healthcare system at large, so that wider, as Paul was saying, the wider, more upstream and midstream area, really failed to recognise the challenges. So in England, we have a lot of performance management and targets and metrics that people in family practice need to attain in order to attract extra funding. And there was a feeling that often they were penalising practices where really the target that was being set was unrealistic given the volume of complex patient need and so on and so forth. And so rather than supporting with more resource, these practices were actually having less. And I've just chosen two quotes there to show some of the challenges that people were experiencing in the deep end, which I'll leave for you to read yourself. Next slide, please. So what's been the impact of the research? Well, we've set up a series of webinars that are networking across all of our deep end practices. We have 38 in our region, and it's about providing that small supportive community of practices working in the deep end together. And it's really by the deep end for the deep end. And the research has led to the co-creation of pilot projects and addressing some of the key challenges that was identified through the co-design work, embedding clinical psychology in primary care, opioid deprescribing pilots, a career trailblazer fellowship scheme, and a train deep scheme to help practices in these areas become training practices, immunisation catch-up, and a pilot to support the social determinants of health, because a lot of things that the people were finding people were presenting for in family care were actually things that were housing related, income related, employment related. And so it was about having those link workers there to work to take people's wider context into account and support them. Next slide, please. So I told you it was going to be whistle stop tour, so I'm going to move on from deep end now and talk to you about the Unfair programme, which really is looking across all of the different areas about how we intervene. Next slide, please. So Unfair research programme, again, you can click on the link to find out more, is all about how, addressing the research question, how can we reduce socioeconomic inequalities and avoidable hospital admissions? It's a 5-year programme of applied mixed methods research, and it's very much a partnership model because it's looking a lot at how systems are working together to address this. So we have a lot of partners involved from a range of organisations, including those working in policy and practice and those in an academic context. Next slide, please. Unfair has four elements to it. So there is an evidence review, which I'm going to come on to tell you a little bit more about. Case study work. So we've done some really deep dives into some local areas, looking at what are they doing to address health inequalities on the ground, with a focus on avoidable hospitalisations, to try and share some of that, capture and share some of that learning. We have a really active public and patient involvement section, which I'd really encourage everyone. I haven't got time to show you the animation, but through that patient and public involvement work, we've well, I say we, I wasn't directly involved because it was very much user-led, but it's about what do the public think and feel about health inequalities, and what do they say needs to change to address them. And I'd encourage everyone to have a look at that animation. And finally, we did some quantitative data analysis looking at varying things that have happened in our local context, for example, cuts to funding of local authorities and so on and so forth, and what impact that was having on local area avoidable hospitalisation inequalities. Next slide, please. So I'll focus on the evidence review for you all now. So we did a systematic review. It's very comprehensive. We screened 23,000 records. And what was really different perhaps about this review was that, I loved Paul's slide with the sort of proximal and then the more middle range and the upstream interventions. And this review is quite unique because a lot of reviews that look at something like the outcome hospitalisations and readmissions, which is what we looked at, tend to focus on health and care, social care interventions, but we opened the intervention side of the review up so that we also included integrative interventions and then population health and cross-sectoral policy interventions as well, things like sugar taxation, seatbelt laws, all sorts of wider and more upstream things as well. So as I say, it was a very comprehensive review, and the protocol is published there for anyone who wants to look in more detail. But I'm just going to skip onto the take homes in view of time. So next slide, please. So the key messages was that research studies infrequently evaluate equity impact. So out of 23,000 different pieces of research that we reviewed for this, there was a handful, 30, that looked at the differential effectiveness by socioeconomic inequalities in hospitalisations and readmissions for interventions. So really a lot of the intervention research was not asking the question about what was the impact of this on equity, and that's a really important point, because unless people start shining a spotlight, we'll not know the answers to what works. What we did find, however, is that evidence of interventions that not only reduced inequalities, but unfortunately also those that maintained and exacerbated inequalities. So the take home from that really is that well-meaning interventions do have the potential to do more harm than good. So it's really important to have an equity lens to your inquiry and co-design and evaluation as you go forward. We found effective interventions, however, across all domains of activity, which really underscores the fact that that whole systems action, not, for example, healthcare interventions alone, are required to address inequalities in healthcare outcomes, which again comes back to the importance of systems working, which is why we're all here today and in the room. And finally, in terms of what were the characteristics of effective interventions, a lot of those were the ones that were upstream, so didn't require a lot of self-agency on the part of an individual to enact behaviour change. However, those interventions that were were more at an individualised level, the key there really was about being person-centred and supportive in design, which comes back to those guiding principles from Equalise around the principles that really support to enable interventions to try and aim to be more equitable. So I guess the key take home there is that patients and the public must be at the centre of everything we do. So hopefully in our 15 minutes just now, I've provided that very brief context setting around the evidence-based guiding principles, examples of activity in England, and I've just chosen two to talk to you about that I've been involved in, which are the Deep End programme and the Unfair Research programmes. And on the next slide, which is just about to come out, and it's my last one, is where to find out more. So there's all of the web links to all of the things about our Deep End research activity, our Unfair Research activity, and then further and wider health and care inequalities research, including some of those frameworks and principles. Thank you once again for the time and having me here today. It's a real honour and a privilege, and I look forward to your questions. Thank you.
Well, thank you very, very much, Sarah. Very encouraged to learn about this, and it really was a whistle-stop tour. There's an awful lot going on. Yeah, and Paul, maybe you could take down the slide just while we chat for a minute here. I wanted to ask Sarah, and anybody in our participating audience, feel welcome to join us here in the chat and ask your questions or your suggestions and ideas about how you are going ahead. But a lot of the things you said, Sarah, I've been working in the space of integrated care for a while, especially there at the end, really resonated. Involving patients, family caregivers, co-design. So I have a couple of questions. One is, you've been doing this for quite a while. I imagine when you started, it may not have had the same groundswell of support and focus that I think it does today. I really think that at least here in Ontario, and I do read things that come out of the UK, it seems to have grown over the years. And do you have a sense of what has driven the interest? And I'll say also not only of social providers who I think have always been in this space, but it's entered more into the space of health. Any idea how that's evolved? Would you agree with that? I don't know. Maybe it's
yes. No, Walter, I think it's a really excellent observation. It's one that I would agree with. Actually, you can track it a little bit as well. So the evidence review I was talking about, where we scanned the 23,000, unfortunately, I say unfortunately just for the workload, we'll have to refresh that search before we publish. And the number of studies that start to mention the word inequalities and socioeconomic, which are the things that really pull through on the search, has grown rapidly in the last couple of years. So certainly speaking from the UK context, one of the key things there has been the COVID pandemic. So if you work as a public health consultant and you've worked in the space of inequalities for a long time, I probably could have drawn for the government before the COVID pandemic, the differential impact of COVID on, for example, by socioeconomic status or indeed by ethnic group that we experienced in the UK. I could have drawn those graphs for them because we know that inequalities are pervasive, and it doesn't matter if you're looking at cardiovascular health or mental health or whatever, those inequalities exist. But I think for us, certainly in the UK, it was a flashpoint for it to get into the political and public consciousness far more. And since the pandemic, we've had through NHS England a very key focus through our inequalities lead Bola Owolabi around what we call the Core 20 Plus initiative, which has been driving a lot of the work that's been going in the healthcare sphere around addressing health inequalities. So I'd say a real catalyst for our activity has been the realisation of the differential impact of COVID, and that has really galvanised, I think, the political and public consciousness as well about needing to act. So it's quite an exciting time to be working in the area of inequalities. I think the thing that I would observe, having been someone who's worked in this area for a while, is that there is evidence out there and evidence-based principles and approaches about what may work and what may not. And I think sometimes it's important that there can be an enthusiasm to act, but as the review shows, even if you want to act, sometimes well-meaning interventions may have unintended consequences. So I think this is where co-design and evaluation is so key as well.
Yeah. And evaluation is a space that I work in, and I'm always trying to think about we've been doing a little bit of work. And as we started our conversation back in the winter, part of it was around measuring inequity and measuring improvements and using evaluation. So how do we do that, and what should we be measuring? So maybe we'll have time for a question on measurement in a second, but I do also have some of the chat. Some people are coming in with a couple of questions. One of them was around the role of the hospital sector And then other people have comments around primary care too, and the ability to engage general practitioners, and here primary care providers in that work. So first, the hospitals, do they play a role at all? And if so, what? And then we'll get to the GP question.
Yeah, absolutely. I think the key there is the integrated element of what we're all doing. I think one of the things that our sort of work on levelling up health showed us was that we all have our role to play. And one of the roles that we have to play is, in ensuring our particular service that we're providing in the hospital context, you have excellence and equity of experience, access, experience, use and outcome from a service, but also understanding where you are in the wider system. So where else can support and help you achieve your aims and ends, and how can we perhaps, if we're both, maybe there's someone in a hospital setting that's doing something that's actually quite or not dissimilar to someone who's working in another area, well, actually, can we pool maybe learning here and share resource even to try and work more closely together? And the sort of most recent iteration in England around the integrated care systems is around trying to get that more holistic join up between what's happening in secondary care and primary care, and then indeed the public health space as well, to address inequalities. So I think hospital is absolutely vital in terms of achieving equitable services. And there's also, of course, the wider role around the anchor institution role of often huge employers in the local area, and have a much wider impact as well. So I think there's an awful lot that hospitals have to do in this space, but it's all about that understanding where you are in the system and how and who your friends are in the system and how we all work together. I think that the integration element's key.
Okay, and thank you for that. And there's going to be some other chat questions now coming in. Then when other speakers are speaking, you maybe have a chance to have a look at them. We won't get to all of them. I will ask the GP question, then we're going to go out to a quick poll and then go into our next set of speakers. On GPs, and I did some work actually with Richard Cookson a number of years back, where we compared the policy to do with the inverse care law that you talked about, of trying to specifically increase the number, because I think it was GPs were everywhere in England, but they weren't as much in the area of impoverished areas. And so we did some policy, and it actually made a difference. More GPs went into those places. And arguably, it had an impact on hospitalizations and premature mortality. Is that do you think that it continues to be an issue, or have there been, that initiative around putting more primary care in areas of deprivation than you had in areas of less deprivation? Was that effective, or are there other policies that or do people still have gaps in engaging GPs? So
I didn't, because in view of time, didn't share, but unfortunately, Walter, the inverse care law is alive and kicking despite sort of previous efforts. There's a quite recent publication by the Health Fund Foundation that outlines some of the inverse care law that's still existing in primary care in the UK currently. So we still have an issue that the areas in the highest need are the most under-resourced. So there is work I know doing on a national level around looking at funding formulas and allocations to try and address this, which I'm sure is building on the work that yourself and Richard did, Walter. I think the intervention that I was talking about here with the deep end is slightly different, in the sense that this is something that's out of our regional allocation, if you like, our health inequalities spend for our area, and our area's decided that they would like to invest more in the family care general practice space, and so this isn't the sort of part of the background funding, if you like, that all GPs get. This is something additional. It's like an extra targeted intervention, and so this is just in those areas where the general practices where they're experiencing blanket deprivation, so the most extreme areas of deprivation. And as I said, there's 30 odd in our area, and this is additional funding for things like employing extra or different staff, clinical psychologists, and so on and so forth. So I think there's still a role that's needed there to address the imbalances that exist.
Well, thank you very much. And I appreciated some of the comments that you had around the link workers. And there's some work I know here in Canada in places and localities around social prescribing, I think, which is starting to step into some of that. we could chat for the rest of the hour on this, but thanks for that high-level overview. I do want to just ask if we could go to that third poll we went by a little bit earlier. Someone can just bring up the poll. I don't think we need to go back to, oh, Paul's got the slide too. Okay. And that is understanding from the people who are participating today, what kinds of activities do you currently have? Are you currently employed with, have in place? Like, are you doing nothing? Are you looking to understand the problem? Have you been designing, testing, piloting, or are you at the implementation phase and you're actually doing some monitoring and scaling of interventions? I'd be interested to see which ones. You can click all that apply, and we've got to wait for people to come in here. We have a little over 160 people now who have joined us today, so there's a lot of people out there, and I'm interested in knowing how active or what you're aware of, if you are not directly involved yourself, actually, what you're aware of locally is going on, if we can get a sense of that. Meanwhile, I'm going to start with a couple of the introductions because we have a lot to go. We are going to hear from 4 Ontario health teams in this space. First, from the Greater Hamilton Health Network, Melissa McCallum, who's the first executive director of the Greater Hamilton Network. And Melissa's approach to her role is also informed by her skills acquired as a master's prepared registered frontline emergency nurse with 16 years of leadership experience. Melissa also has a passion, driven by her passion for working with partners to create an integrated, equitable health system. So I'll really appreciate that focus from Melissa. Then we're going to go to Central West, where we're going to hear from Kimberly Floyd, and Terence Rodriguez from Rexdale. Kimberly was previously the Vice President of Home and Community Care, Central West, now CEO of Well4 Community Health Services, where she guides the organizations towards a comprehensive model of health and well-being. I met Kimberly. She was a master's student at HPME a number of years ago, and she recently won an award for her leadership in the community. She'll be paired with Terence Rodriguez, who's a trans Latinx European social worker born and raised in the Rexdale North Etobicoke community. We share that in common. Terence, I grew up in around Kipling Heights in Rexdale. He's founder of Rex Pride, who's worked in the sector for over 15 years, 11 of which he's been focused have been focused on working to address the barriers faced by the 2SL LGBTQ+ community in the community through youth programs. Then, why don't we share the results while I just do a little bit more to introduce Chris Fatah and Ashnor, who will come after. Chris Morah is the Director of Integrated Care Systems and Partnerships at Humber River Health, one of the executive leads, where they're focusing to integrate health and social care to reduce health disparities in Northwestern Toronto. And I think if anybody saw the COVID maps, we know there are disparities there. Chris has over 10 years of experience and holds a master's in medical law ethics from the University of Edinburgh, which I would say is an excellent place to learn about integrated care and social determinants. He'll be joined by Fatah, who is a health system planner, health equity advocate with the Northwestern Ontario Health Team as well. He's worked with community public sector nonprofit organizations. He was involved in municipal politics for a little while. He's a member of the Equity Mobilizing Partnership in Community. That's MPACT. If you've not heard of this group, you should find out what MPACT does. They are currently involved in health equity assessments on project decisions and health system stakeholders. And Fatah used to work with us at HSPN many years back. He said might have triggered him onto doing this kind of work in the first place. Finally, Ashnor Rahim, who has joined the KW4 Ontario Health Team as its inaugural executive director, following 25 years of experience in a variety of health settings. Ashnor may be well known to many of you. She's a health system leader committed to improving the overall health of Ontarians by creating those coordinated and integrated delivery models focused on improving health. And we're going to be very excited to hear from all of these speakers, and we're going to have to be careful to do it in a timely way. So what are people doing? Some people aren't doing much. Some people are understanding the problem, but 67% are doing that, which is a very important foundation. Designing interventions, almost half of our audience actually in this space. So today you might get some ideas about where to go. Testing and piloting interventions, a few people are already doing that. We're well represented today by people doing that. And finally, monitoring and scaling. So 12%. I'm heartened to know that people are out at that level of implementation. So really good to know that there is some activity, but understanding the problem and thinking about solutions is our focus today. So without further ado, Melissa, how about you go ahead?
Thanks so much, Walter. You can go to the next slide, Paul. I just wanted to start that health equity has really become the foundation of our Ontario Health Team work. The Greater Hamilton Health Network serves a very large population. We have about 700,000 individuals attributed to our OHT that actually span 3 geographical regions. That's Hamilton, Haldimand, and Niagara Northwest. One quote that's guided me is, "Do justice to our voices and showcase our experiences that usually get dismissed." I do feel strongly and come from the point of view that these stories, this evidence has been there for a very long time. It is the solutions that and the actions that we need to focus on. Next slide, please. When the OHT was first starting, obviously there was a lot of things going on. You know, the COVID pandemic hit very soon after. Most of the first OHTs were just getting up and running. But, the COVID pandemic also highlighted, like we can all agree, the inequities that were already in our system for a very long time. So how did our OHT use some of these inputs? Well, we started to look at community voices more in depth, listen to lived experience, take the historical reports. There has been a lot of work, especially in Hamilton and the GTA, about the data about health inequities, those that are not accessing care, those that are. There are very well done reports that we could already access to know and use as a starting point for this work. We spent the first 6 months of our OHT actually doing a health equity framework and supplementary report. We wanted to hear from specific communities and priority populations within our OHT about, how care was, what was missing, and what their recommendations as we move this new kind of OHT model forward, where was the best, launching point for us? Coupled with the fact that there is strong, SDOH data and heat maps, healthcare outcome data that some of our partners actually already have. I think one thing, and I just wanted to highlight that I've learned over the last few years working in this space, is that being very mindful that these stories of health inequities have been told over and over again. They've been told to healthcare organizations, they've been told to people in leadership, but there hasn't been a ton of action. And in Hamilton proper, we see the life expectancy between, certain wards almost 20 years still. It's been like that for over 10 years. So just wanted to kind of throw that in, that these are stories that are there. But it's a difficult starting point because they've been heard, but there hasn't been action. Next slide, please. Today, I want to talk a little bit about 2 initiatives that the GHHN put in place when we wanted to address health inequities of the populations within our OHT catchment. These 2 initiatives recognize that people are extremely complex, that they present with multiple issues, and they take into account the whole person. We very much took the mindset that we were not going to focus on one small portion of a healthcare disease, but rather think about initiatives that looked at the whole entire person from a health and social lens. The first example is around homelessness. The concern that we were dealing with was that, especially during the pandemic, women were presenting to shelter in high numbers. There was increased rates of homeless men being turned away from these shelter and day spaces. Women accessing shelter were becoming extremely complex from a medical and social point of view. We actually saw an increased rate of pregnant homeless women. And then we already knew from that historical data that there was inequities in funding and bed counts for women who were homeless in the system. We brought together our OHT partners to think about a co-design initiative. We went out to see women who were accessing shelter and day spaces, and we brought around the providers. And I'm not talking about just, ministry funded providers. I'm talking about social providers, food banks, not-for-profits, charity organizations to develop the intervention. And in 2021, we came up with the Women's Homeless Health Drop-In Days. These would be low barrier, free clinics that combined health and social care delivered to where women were served. So they were held at shelters or day spaces, and they provided, a whole host of things, from primary care to STI testing, cancer screening, pap smears, mental health care, newcomer services, naloxone training, but then also coupling that with social activities, art, food, gift cards, menstrual products for free. No appointment was necessary. It really became this one-stop shopping clinic space. We decided to hold this since 2021 once a season, because we also knew that as the seasons changed, the women's needs and concerns changed along with them. The results have been honestly quite staggering. We've seen over 550 women in 8 days since 2021. We've had STIs identified on site. We've accessed housing and healthcare at that point in time, delivered wound care. An amazing story from one of the days was that a woman who accessed the event got point-in-care hepatitis C testing, was positive, did not know that, but went to the next booth to actually start her treatment. Everything was there. It was trauma-informed. It was, coupled with peer support. And there's been a couple of things that have really branched off since doing these clinic days. We discovered that reproductive access was not even known within our GHHN catchment area. So we just developed the first ever abortion care pathway, which has now become the most accessed pathway on our primary care site. We've started to collect race-based and socio-demographic data at all of our clinic days, and this has actually helped inform the next days to come. But overall, it's honestly built trust between our OHT partners, the people accessing the event, and even periphery, people wanting to be part of something that feels really low barrier with a harm reduction lens. Next steps, we've just actually last week expanded these clinic days to men. We partnered with a church and a local drop-in center called The Hub. We saw 142 men in 8 hours in the shelter and church parking lot using the same kind of idea. And we still continue Women's Health Days every single season. Next slide, please. The second example I want to talk about is housing. So the concern that we were up against was that low-income housing units within the core of Hamilton were actually being decanted and deemed not livable during the pandemic. But during this, decanting and realizing that, there are a lot of vulnerable individuals living in low-income housing in Hamilton, often the first homeland of homelessness, it revealed countless other issues in the vulnerable housing sector. So again, much like Women's Homeless Days, we brought together some partners. We started to engage with the owners and operators of residential care facilities, which are these kind of group home environments within Hamilton. Again, low-income housing, they're subsidized mostly by the city. They're often a first home out of homelessness or a home out of hospital care. We developed the Residential Care Facility Integrated Care Initiative. And what this was wrapping around a comprehensive primary and social care team around vulnerable housing environments that serve low-income individuals. Based on, healthcare data use, what we were hearing from on the ground, partners with lived experience, people with lived experience, we chose 4 homes in the core. And these homes really felt disconnected from the system. They were part of this housing continuum, but they did not have a care environment wrapped around them, even though they actually house some of the most complex individuals in the city, extremely complex mental health and addictions, chronic disease, and poverty. The results of our integrated care initiative for the residential care facility were that primary care started to become delivered to the person's home for the first time. We assigned a primary care integrated care team to wrap their arms around these homes. They started to come on site once a week. Every person that lived there was offered a house physician. But with that house physician came, community connectors, nursing, home care coordinators. Not only did the care come right to where people were housed, but advocacy issues for things like pests and making appointments and the safety of the home really actually became a team effort. So the community connectors came into these homes. They helped to bridge some of the health and social care, help get people off to cancer screening appointments, dental care. We did some cultural safety and training, even just naloxone training for the staff that work at these homes. We heard from people that live there. We feel like we're put on the map. We felt like we were forgotten. We've actually completed some research on understanding the care needs of people who live in these environments, which has actually never been done before. So in terms of next steps for the GIN for this work, it's being used to inform a redesign of the entire residential care facility system in Hamilton. And just this year, we were awarded a $1.2 million grant from the Juravinski Research Institute about improving equitable access to integrated primary care in these facilities. And I know my time is up, but I just wanted to end with a couple of key messages from our experience. And something I actually heard last week that I wanted to share with you from a group in New Zealand was treating the data as neutral, not as a weapon. People require our help and our support no matter where they are. Let's use this information as a shared collective to do some action. We've really learned just to go. There was way too much time spent in analysis. And I think we all can hear that analysis paralysis is a huge concept. But the further we just analyze, it further erodes the trust with people that are working in the community and those that need our help. So always using our collective muscles together and then adapting. I want to mention that for us, every single partner has a place in this work. I do not believe that our OHTs will be successful if we only focus on health providers. We need those social and community assets, churches, small charities, food banks, not-for-profits, education sector, volunteer organizations. There is tremendous power in equity advocacy as an OHT. We need to be able to organize partners that don't have the time to apply for funding ahead of time. We've been ready for this and received funding because we've actually put in the work with those organizations that just haven't been at the table before. We need to recognize that organizations and communities already do equity work very well. They just haven't been fully recognized in our system. And then we have to listen to communities. This cannot be another checkbox exercise. The acute needs of people who require help and support is just too much right now. So I'll end there, Walter.
Thank you, Melissa. And, of course, we could also talk about this, and I'm just going to hope that I see great Kimberlin's already coming on, and Terrence will be in a moment as well. And we're just going to keep moving, and we'll use the chat to keep the conversation going. Such interesting initiatives. Go ahead, Kimberlin.
Great. Thanks, Walter. And hello, everyone. It's really great to be here with my colleague to present a little teaser of what's happening in Central West Ontario Health Team. We can move to the next few slides, please. You can keep going until we get to the OHT CQUIP, please. So I have the pleasure of being an executive sponsor with our OHT around a collaborative quality improvement plan focusing on cervical screening in our community. If we can go to the next slide, please. We knew that we already going into the pandemic had lower cervical screening rates than other areas in the province. And yet we really saw this impacted during the pandemic. We knew, though, that the interventions needed to really be tailored to understand the communities, and that's what we're talking about today. We can move to the next slide. So just a little background. We took the opportunity to look at all the really great data that existed provincially to try and understand the problem, to Walter's point a few moments ago in the poll. We were able to zone in and look at specific postal code areas where we were seeing difference in access to services, seeing difference in breaking down barriers to care. So you can see on this slide, we had the opportunity in our OHT, as Melissa has talked about, it doesn't take one provider, it takes all providers. And so we started to looking at where there was synergy or intersectionality of providers that were already in certain communities, had some trusted relationships, but also needed a focus. So the four postal codes on the screen were areas that we wanted to target in order to improve care delivery. We can go to the next slide. So we set a bold and ambitious partnership. Some of the comments that have been in the chat, Wellfort, that I have the privilege to be the CEO of, is a community health center here in Peel Region. We work closely with our Rexdale Community Health Center, as well as other family health teams and other primary care practices. The three of us as three primary care organizations said we're coming together to actually tackle this problem together and really look at strengthening community-based care. This took a leadership hat that said, I'm not only going to improve the care inside the walls of where we're delivering primary care, but we're going to take on that increased accountability and responsibility to support the entire population area within our geographies. It also created the opportunity to challenge ourselves to say, how do we use our EMRs? How do we embed data collection consistently? And for my ministry colleagues and other researchers, I think the mic drop moment is we don't collect data the same way. And so this was an opportunity to come together and say, we're going to change that so we really understand the needs in our community and our population. If we move to the next slide, the intervention that we focused on really highlights that some of those components that Sarah shared with us at the beginning of principles. We knew that there was the individual inside the walls of a clinic and how people had access to cervical screening, but there was more than that. There was also that population health perspective. And we leveraged elements of high priority community strategy that was underway in this province, as well as the collaborative QUIP and that shared commitment in this OHT to say, we're going to focus on that clinical perspective, which you can see in these blue spokes that are moving about. And that's everything from understanding how we're funded in primary care, to how we put data in our EMR, to how we pull data out of our EMR, whether people have OHIP coverage or not, and all those kinds of elements were moving parts. But in addition, we wanted it to be more community-centric. And so understanding what are the barriers if someone is unattached to primary care? What is the barrier if they can't get transportation, if they can't get childcare? So when I talk about being ambitious, we knew that we were trying to tackle all of these things at once, but using the leverage of strong initiatives that were in this province at the time to bring together an intervention. We, when I think about Sarah's overview, we tackled the connectedness of different programs and funding opportunities. We looked at the intersectionality of some of these elements. We created a flexible approach to care, and the other pieces, we're not finished yet, still got 6 months to go, so lots of exciting pieces. We also leveraged things like a mobile health outreach approach. So similar to Melissa's comment about the clinics, it's bringing those clinics close to people's homes and created the trusting relationships. We can move to the next slide. So the actual intervention of our future state has these components. The commitment to measuring cervical cancer screening the same way across all providers. We're starting with our 3 primary care practices now, also working with the EMR vendors to talk about how can we continue to leverage this. We believe we're going to have more real-time data for these targeted postal codes than the ministry will be able to have. And it'll be at our fingertips, and the kinds of interventions we'll be able to watch what happens with our data. We also are committed to breaking down those structural access, cultural components, all the things we're talking about here about inequities, and really make sure we break down those barriers. We're also going to, out of this, standardize the cervical screening process. We talk from everything from health promotion all the way through to if someone is diagnosed, how are we going to support them and treat them? We also, if we move to the next slide, we also knew, and to some of the comments in the chat, I want to do a shameless plug for your community health centers in this province. If they're not strongly engaged in your OHTs, I strongly encourage you to bring them to the table. The CHC model has been doing focused work on equity deserving populations for many, many years with lots of research and lots of demonstration of outcomes. We knew that in our practices, we could collect sociodemographic data and pull it out. That was going to serve the inside the walls. But what about the population who is part of our OHT but wasn't attached necessarily to our primary care practitioners? We now have both data collected from a population health perspective of these folks in these postal codes that we're supporting, as well as our inside the wall primary care data. And now as an OHT, we can better understand where the gaps are and what we need to do for interventions. Really quickly as I close off, we can move to the next slide. That component of really allowing the community to co-design and give their voices. This is the work that we've been embedding our high priority community strategy team members in really getting out there and understanding. And I'll leave it as a teaser. We now know what some of the barriers are that help people have access to cervical screening, and we're creating cervical screening initiatives that tackle that. And last but not least, just to leave you as the summary of some of the screening and the lessons we've learned so far. We need to do that Western medicine approach to standardizing clinical practice for sure. And by coming together as 3 primary care practices, we're really starting to advance that now and have some aha moments about different populations and segmenting care. But we also know that data collection including both clinical and sociodemographic data is really important to our OHT to advance population health. We also really need to understand these neighborhoods. And so listening to communities and understand the equities that exist and what the unattachment rates do to how people access care from a primary care perspective has been foundational for us. And last but not least, we're going to increase those clinical access elements to improve population health. Thanks, and I'll turn it over to Terrence to talk a little bit about a couple of the other nuggets.
Excellent. Welcome, Terrence.
Awesome, thank you. All right, next slide, please. Y'all can see my camera, right? So I'll speed through this. I'm not going to go through all the details. Another example we're going to be talking about today is the mammogram programs and engaging the ACB community. So since February, we've been working with the local hospital in Wellesley to create a program where we can support people to get access to mammograms. But before that happened, we realized we also needed to educate. We needed to address some concerns and fears and myths, and address other needs like food security and things like that, because there's many aspects to a person's identity. So this program was very small in group settings, and it happens weekly, and it allows folks to address some of their concerns, answer some of their questions, fears, things like that, and in the group itself created a little sense of peer support as well. And so it's been a great program. And so if you can go not the next slide, the one afterwards, you don't really need to get into the myths. So some of the folks that we've engaged, ACB has mentioned, if y'all don't know the acronym, there it is. Age group 50 to 74, last mammogram 2 years, no previous breast cancer implants, OHIP, no HIP, you got all that jazz there. So we did have some set criteria. And next slide, please. So again, I'm not going to read through all this, but there was a process in regards to accessing this program. The screening by the nurse practitioner, and then requisitions and the appointments. And we actually went with the clients who were scheduled that day to the appointment, so they weren't going alone. And we initially had done, after the screening, a lunch plan where we could have a debrief and over meal. Debrief still happens now, but they actually much preferred having a gift card because they like to purchase groceries as we're addressing food security. So it makes more sense to spread out those dollars doing some grocery shopping for the family versus a meal, since things are so expensive right now, inflation, everything too. So that's where we've gotten to that. That's what we do in that program. Next slide, please. So you'll see just some breakdown in numbers and what we've been able to achieve. 119 screened, 127 are up to date on their screening, and we've had 3 abnormal results. Next slide, please. So, actually, I already covered all this stuff, so you can go to the next one. Try to speed through because I know time wise. We do have some testimonials you can see. In addition to this, we also have what's called Be Well clinics. I don't know if you've heard of those. I don't believe we have a slide on that, but I just want to touch upon it. It's these community clinics where they started as clinics and now they're like events. We have not just clinics, we also have social services, we have entertainment, we have African food basket, we're giving out fresh food security, we have physical activity, we have just a gambit of things. We even have folks from the community coming in and telling their stories to hear from each other and some lived experiences. It's just really a community event, which started to be monthly. Now we're going to move to quarterly, but we are going to maintain, they're called the Be Well clinics, and they're geared specifically for the ACB community, created by the ACB community. All our community partners are all ACB from the community, as well as organizations that service the ACB community, whether it's locally within our geographical area or citywide. We meet weekly to design, plan, leverage, evaluate all that. And this has also been an evolution where now we're working with Black Health Alliance and Health Commons and BPO, Black Physicians Association of Ontario, to try to capture not just what we're doing, but the impact of it, to try to advocate for some of the needs of the ACB community in regards to this. The other last bit is we have with Black Creek Community Health Center, we have a mobile clinic coming in. So when the pandemic hit, and y'all been talking great about this and using the client-centered approach, pandemic hit, a lot of folks that weren't from the community didn't know that these things were happening, although we could have told you well in advance that this was going to happen. And we had to do a lot of education and advocacy for the needs of the community. One of those was accessibility needs, having clinics that were more accessible to the community. So we created those pop-up clinics for the vaccines. So that actually ended up leading into the conversations in regards to healthcare in general and how to make it more accessible. So we're going to have mobile clinics that'll be happening soon. We have an actual bus, like a van, that will be offering primary care and bringing physically to the communities and offering that. So right now we're in the communities getting surveys. I think we've done over 500 between Black Creek and Rexdale so far to find out from the ACB community what kind of services they would like, how we could, engage them, what are the things they'd like to see in regards to it. So that's where we're at with that right now. So
That's great.
Okay.
And I think that's that iterative process also that we saw in Hamilton too, of collecting data, identifying the needs, and then pivoting towards that goal. I think it's just amazing that you're really spending the time and meeting people where they're at there in those programs and helping them.
It's leveraging ambassadors big time, and it's always just, as we're all saying the same thing in this, it's client-centered. Everything is always client-centered approach.
Thank you very much. It's so interesting for us to learn today about people who are actually making a change in people's lives. We try to support that work here at HSPN. Often what we mostly do is provide data, as well as convene these events where we get to share this information. And people are talking about data-driven approaches. We're going to see another one here, Health Equity in Action, with Fatah and Chris, and I look forward to seeing it. And I love that we're going to see a use of some HSPN data here as well. So go ahead.
Thanks, Walter. Good afternoon. Fatah and I are really excited to be here to share some of the health equity initiatives that are underway at the Northwestern Toronto Ontario Health Team. Before we share a bit about our current work, we thought it would be helpful to share a little information about the Northwestern Toronto Ontario Health Team. Our OHT is a part of Cohort 1. Currently we serve over 400,000 people. Our OHT has 14 partners across these sectors: acute care, community health centers, home and community supports, long-term care, mental health and addictions, and primary care. Currently, our OHT is entering a different phase of maturity, and we're continuing to build an enabling environment to support population health management and integrated care. However, at the heart of everything that we do is health equity, and this is because of our community. I would like to turn it over to Fatah to share just a bit more about our community. Next slide.
Thank you so much, Chris. When we talk about the Northwestern Toronto OHT, we're talking about an Ontario Health Team with a number of challenges. And I want to share with you just a few of those challenges by highlighting some key indicators. And an indicator on your left that is strongly associated with poor health is material deprivation. And this is where HSPN data comes in. So when assessing material deprivation, which tells us whether someone lacks access to basic needs, such as education and employment, the Northwestern Toronto OHT, our OHT, has the highest proportion of the population that falls within the most deprived quantile among all phase 1 and 2 OHTs. Additionally, on your right, there's also very low attachment to primary care physicians, highlighting a need for more primary care doctors. We also have an imbalance when it comes to the provision of mental health care. We rank among the lowest when it comes to number of mental health providers when compared to the high levels of mental health disorders in our OHT. Moreover, there is also a higher prevalence of chronic conditions within this OHT compared to the rest of Ontario. Lastly, this population experiences housing instability and challenges attaining basic needs, with 59% falling within the lowest quantile of the marginalization index. These inequities and challenges highlight the exceptional health equity needs of this population. And in order to address these challenges, we at the OHT went about developing a tailored health equity strategy for our OHT. So what went into this approach? Our approach to developing a health equity strategy involved a multi-step process and was developed in partnership with our OHT partners, along with support from coaches through our involvement in an 18-month-long Pursuing Equity Learning Network hosted through the Institute for Healthcare Improvement, and as well as support from the community. Our process began with a scan of existing strategies and local best practices, along with the review of the literature. We also engaged the community through running a number of focus groups within OHT. And then we went through many iterations of the strategy, revising the strategy as we learned more about the unique needs of the community. And then the next slide, please. Thanks, Paul. So what did we land on? By engaging in the approach that I had gone through, we were able to land on two major iterations or two major versions of the strategy. The first original version of the strategy consisted of 11 domains that corresponded to the 11 areas of action areas that you would find within Ontario Health's equity, inclusion, diversity, and anti-racism framework. We took these 11 domains and went through a process of building from it, defining strategies and sub-strategies, going so far as detailing metrics and level of implementation for each domain. However, what we assembled was large in scope, and due to framing and sizing, we went about developing a more tailored and community-facing strategy and consolidated much of what we had developed. We wanted to develop something that really spoke to the needs of Northwestern Toronto OHT, given the inequities. And so we worked with external partners to conceptualize the strategy into something that was a bit more tangible and could make the strategy more relatable for community and our partners. So on the next slide, please. So in hopes of sharing something that was a bit more relatable, what did we conceptualize? We developed a health equity house. Why a house? A house has different parts, and it is something that you build. And like a house, we are building health equity in Northwestern Toronto OHT. And when you build a house, you start with a foundation. And with our health equity house, we have a few foundational principles in the foundation from which we are building from that are helping to guide our actions. Next, building off of that foundation, we have the main body of the house, which contains the main domains or areas of focus. These are the buckets of work that are our priority for our OHT, and we've divided these domains into two larger categories. And that is work that needs to be done that is more OHT facing with our partners and work that is more community facing. You may see, for example, that some of the domains repeat in both of these categories, and that is because advancing racial equity, for example, looks different when considering what needs to be done that is more OHT partner facing versus more community facing. And likewise, including and engaging key voices looks different when considering the role of the OHT compared to the community. And lastly, we have the roof. We look up at the roof. These are aspirational goals that we look forward to when engaging in work under each of these domains. And this is a draft, but we hope to fill that roof with aspirational goal statements that speak to the impact that we are trying to make through the work within that main body. And lastly, I do want to say that we hope to build on this conceptualization. We may include an open door that speaks to open participation and involving community and partners. We may include a window where people from the outside can look in and see the work that we are engaging in order to build transparency. And lastly, we may add a garden that symbolizes the activities and health equity projects we are planting. And next up, I'll give it back to Chris, as you'll get to hear about one of those seeds that we are planting that connects to our health equity strategy and the domain around building capacity to improve health equity.
Thanks, Fateh. So how are we going to bring our health equity strategy to life? One example of this is that our OHT committed to developing a community care hub that would integrate health and social services with the intent of reducing health disparities. Now, this commitment included in-kind contributions from many of our partners, including Humber River Health and Black Creek Community Health Center. Humber River Health was kind enough to provide a space for the hub. The space is located in a Toronto neighborhood called Glenfield Jane Heights. Now, this area has been identified as one of the many neighborhood improvement areas in the city of Toronto. Now, these are neighborhoods that received low scores on the city's urban health equity assessment. Now, this assessment evaluated domains that included economic opportunities, social development, participation in decision-making, healthy lives, and physical surroundings. Also important to note that Black Creek Community Health Center's Executive Director, Cheryl Prescott, is the executive sponsor of this project. Now, in early consultation with our partners, we wanted our hub to incorporate the foundational principles, domain, and overarching goals of our health equity strategy. This means that we wanted to co-design the development of the hub to ensure that we were building something that would be beneficial to the community. This would include identifying services that would resonate with our community, but also thinking about the day-to-day operations and cultivating the kind of experience that our community would want from this hub. Next slide. The following slide highlights phase one of our planning process. The project began about 6 months ago. The project began with an information gathering component. As part of the project, we developed a data brief of our community. Specifically, we wanted to identify the key health and social needs of the community surrounding the location of the hub. Additionally, we met with OHT partners to discuss and brainstorm how we could address some of the health and social challenges within our community. Now, this followed extensive community engagement with the community. We also brought together a community advisory committee made up of local agencies, frontline staff, and community members to flesh out the scope and potential service offerings. And we are currently developing our final report that will consolidate the findings from the previous stages of work, and this will have concrete recommendations for our OHT to action. Now, as we begin to plan the operations of the hub, we will have a soft launch next month. A few partners will move into the space and begin to provide services. Next slide. Now, based on our engagement, some of the preliminary recommendations is to offer a hub that will integrate health and social care. This would include offering mental health and addictions counseling, chronic disease management, employment services, and social and recreation activities for seniors. Now, on the left-hand side, there's a picture of our community engagement session that took place at Black Creek Community Health Center. During this engagement session, our community shared that they wanted to have improved access and timely care, and they also wanted to receive care from a diverse group of healthcare professionals. Next slide. Here's a high-level overview of our next steps. As mentioned, once our final report is completed, we hope to operationalize the hub, and this work will continue to be done in collaboration with our community.
That's really great.
Thank you.
Yeah, super. Thanks for closing. I'm going to go straight to Ashnor because we are close to time. And so Ashnor, you go ahead and you can close it out. I'll need 1 minute to close at the end. So.
Thanks, Walter. I'm hoping someone's going to take my video off so that you can see me at some point. So thanks so much. And I have the dubious honor of being last. So I'm going to try to motor through this information so that you have some time at the end. So really delighted to be talking about some of the work that's happening at the KW4. And just in case some of you are wondering, the KW4 actually stands for Kitchener, Waterloo, our two large cities, and then our amazing surrounding townships of Wilmot, Woolwich, and Wellesley. So in terms of the agenda for today's discussion, really, we're going to start by sharing a bit of information about the KW4 OHT, and then talking about how we've used data to help inform and develop some of our health equity focused work. We're going to share an example of one of our initiatives focused on our priority neighborhoods, and then finally some lessons learned that make doing this work a privilege and an opportunity, but also a bit of a challenge. So let's get started with respect to our population. So the KW4 OHT is one of the fastest growing cities in the province as well as in the country. Looking at our census data, we know that we have had a 5-year growth rate that's approximately 11%. And when you compare that to the Ontario and the Canadian average, you can see that we're growing at a really fast rate. And that when you look at the growth, what's interesting is that in particular, this growth is tied to our newcomers and individuals coming into the country. So almost 53% actually of our growth is determined by the newcomer growth that we've had in our cities and region. Next slide, please. So immigrants, as we talked about, account for a large portion of our population. And certainly in our overall in our population in the last 5 years, we're continuing to see this grow. What's important is that of the new immigrants, we have seen that this isn't just students. So we have 2 large universities in the region, but we've also seen from an economic perspective that we have individuals coming from Afghanistan, Syria, as well as the Ukraine most recently. And so this is really starting to shape our equity discussion, if you will. Next slide, please. So really, we needed to better understand some of the challenges and opportunities that were faced, that our newcomers were facing. And so what we did last year was we ran a project looking at what were the experiences of newcomers, because we know that when our newcomers arrive in Canada, their level of health is actually greater than 4 or 5 years after that. And that these declines in health that are seen 4 or 5 years after are actually tied to the social determinants of health. So in the summer of 2022, we created a process where we could journey map our newcomer stories to better understand what was working, how they interacted with the healthcare system, and the opportunities for improvement. We also wanted to understand our newcomer population. And so we know that in looking at the data related to who's coming from where, we understood that many of our newcomers were very well educated, that their formal education was actually higher than the average of the individuals living in KW, and that they were very digitally savvy. And so that was important when we started to think about some of the work that we wanted to do. What we learned from our interviews was that many of our newcomers were keen to self-navigate, and that often weren't able to find the information themselves in order to make decisions, that they were dependent on our systems that were very people focused and going into certain places, etc. And so trying to think about that as we look at how do we need to evolve our systems. We also learned that many of them had challenges accessing healthcare services, in particular finding access to primary care services. But that although that was important, it was equally, if not as important as finding a job, having access to shelter, access to social supports. And all of them talked about mental health challenges and the difficulty in accessing the mental health services across our region. So our hypothesis was that if we could better understand the needs of our newcomers in the first 5 years, that we could maintain their health and possibly prevent the decline. Melissa spoke about listening to our population and then working with them to build change. And really that's what the newcomer journey mapping is about. Next slide, please. So our recent data shows that the highest portion of our marginalized population, which includes Indigenous peoples, visible minorities, newcomers, live in 4 priority neighborhoods. And so by looking at the data in terms of health data for these neighborhoods, we could start to understand what were some of the challenges in these neighborhoods. So for example, these neighborhoods represent about 18.4% of our population in KW4, but they represent almost 35% of our ambulatory care visits to our hospitals. And this includes angina and asthma, COPD, diabetes, and a couple of other conditions as well that often we see ED visits for. We also recognize that this almost 18.5% of population represents over 32% of our ALC visits, our ALC. And so we're starting to see that these individuals, once they're in the hospital and are finished their care, can't necessarily have the resources or the supports to be able to go back into the community. We also know that 30.4% of the inpatient days are attributed to these 4 priority neighborhoods, and that finally almost 44% of our frequent emergency department visits for mental health and addictions is tied to these priority neighborhoods. And then as of June of this year, we have data that shows that these neighborhoods account for 30% of the patients that are registered in Healthcare Connect in hoping to find a primary care provider. Kim spoke about cancer screening, and certainly in these neighborhoods, we have the lowest cancer screening rate in our region. And it's 14 to 17% lower than the screening rate for some of our more better performing neighborhoods. So you're really starting to see the disproportionality of health equity playing out in these neighborhoods. Next slide, please. So for us to start to focus on this work and share this information, we wanted to first bring together our providers in these neighborhoods so that we could start to share some of this data. We wanted to understand what were the services that were being offered, how were they connected. Knowing a little bit more about these neighborhoods was also very important to us. Do they have access to food? What's the housing situation like in these neighborhoods? Is there easily accessible public transportation? So what we did was we brought together our providers who deliver care in these neighborhoods, but we also partnered with the University of Waterloo to better understand best practices and evidence-based care related to social prescribing and the importance of the social determinants of health. Once we were able to pull these groups together, we wanted to work with our community agencies and our community providers as well to start to build and develop some personas around the priority populations within these neighborhoods. So through a series of several workshops, many of which were in person, and we had over 40 to 50 people attend these workshops, each of them, we started to develop 3 pathways that helped to, if you will, put a face to some of the challenges that were being faced in these communities. And we were able to develop 3 personas. The first one was related to a senior with a heart failure. And this is one of the largest ED visit causes in our region. Certainly a diabetes pathway related to our newcomers, because we know that chronic disease in our newcomers is growing at an alarming rate. And then a third one that really came from, I would say, our community partners and our community members was youth transitioning to adulthood and accessing mental health services in that transition spot. So these pathways focus on supporting community members within the community with the goal to improve overall wellness, but also reduce hospital admissions and readmissions. Next slide, please. One of the things in speaking with Walter about this presentation was some of the lessons learned, having been involved in health equity work for a number of years. And I think it's important that we think about them as we do this work. So first of all, we know to achieve improved health and wellness, we need to take a population health approach. So an episodic or a reactive approach really can be quite limiting and doesn't allow us to create a learning health system. So how do we consider traditional funding models using a population health approach? Second, a population health approach with focus on health equity helps us understand the issues faced by our communities and create more comprehensive care plans that impact our system indicators. If we continue to focus on system indicators without taking the time to understand the hyperlocal or population differences, we won't actually be able to improve the system and move the needle. For some, this work may feel new and requires that all levels of government are aligned with respect to their priorities and goals. It's not an or, but it's an and. So for example, when we talk about translation services, which I'm sure many of you are familiar with, having access to a preferred language is important, regardless of whether you're going to speak with your primary care provider or you're looking for a job. And yet one of the common tension points that we see is that translation services is seen as a health function only, rather than something that as a newcomer would improve your health and wellness overall. And finally, with respect to evaluation, it takes time and requires providing support and education to our non-traditional partners. So for example, working with our settlement agencies, as well as our hospitals and our community agencies, including our grassroots agencies, is a very different approach than doing research or performance measurement and management within a hospital alone, for example. And so the level of understanding and knowledge can vastly vary. And so how do we manage that in order to ensure that we're able to measure and evaluate authentically? And then finally, this is a long journey. And the indicators that we use may need to expand to consider non-traditional healthcare indicators. So for example, by using the quintuple aim to allow us to better understand our impact, we can start to influence the system and improve health equity for all in our communities. Thank you.
Thank you, Ashnor, and thank you, Chris and Fatah and Terrence and Kimberly and Melissa and Sarah and Paul, and in the background, Trisha and Nusrat, and for the 150 people that were on this, or more than that actually today. Thank you to you all for your engagement. Hopefully this, I've seen some notes in the chat about this raising it. Paul, we can just go to the next one. We're very interested in your feedback. You can scan this. There's a link in the chat for feedback on this and future webinars. We are really building in a whole line of work related to health equity here at HSPN, and we are very much looking forward to engaging everybody in this. Look forward to it. Thank you very much. Have a lovely afternoon. We'll see you next month when we will have an equally interesting discussion on patient engagement. And that one will be delivered in collaboration with IFIC Canada. Watch for the invitations coming from us, but also from IFIC Canada. And we'll be back in November with digital. Take care, everyone.